Hey guys, welcome back to my channel, The ENT Resident. Today I'll be doing another case discussion on another topic which a lot of you have been requesting me for a while, and that is about a solitary thyroid nodule. So we'll start with the history of the patient. We'll discuss each of the history points and what does it indicate, a few viva questions related to it. Then we'll move on to discuss the clinical findings. We'll reach our provisional diagnosis. We'll talk about a differential diagnosis and how we'll manage the patient. You can also now purchase my notes. I have added links in the description. Okay, let's get started with our case. So, Rohini, a 36-year-old female residing in Mumbai, homemaker by occupation, presented with the chief complaint of swelling in front of the neck for the last 3 years. Moving on to history of present illness, patient is apparently asymptomatic 3 years back when she noticed a swelling in front of her neck, which was insidious in onset and gradually progressive to from the initial size of 2 into 2 centimeter to reach the current size. Now, moving on to the next part. Now, negative history is not a title that you use when you're taking your history sheet, but I'm just writing it like this so that you understand what are all the other complaints that you should find out from your patient when a patient has presented to you with a complaint of swelling in front of the neck. These are all the histories that you should be taking. So there is no history of change in voice, pain, fever, difficulty while swallowing, pain while swallowing, difficulty in breathing, noisy breathing, palpitation, chest pain, change in appetite, change in weight, heat or cold intolerance, irritability, tremors in hand, lethargy, double vision and bulging eyes, diarrhea or constipation, cough with hemoptysis, swelling elsewhere in the body, surgeries in the neck, radiation exposure, and no history of any near ear or nose complaints. So then moving on to past history. So there is no history of any other disease in the any other medical disease, no history of surgeries in the past, no history of drug allergy. This is very important. No history of intake of any thyroid related medications. Coming to family history, there is no history of similar complaints in the past, no history of cancer or cancer related deaths in the family. Coming to personal history, sleep is normal, appetite is normal, non vegetarian diet, and bladder and bowel movements are normal, and there is no addiction history. Next, in this case, it is also important that you take a menstrual and an obstetric history of the patient as well. So, the patient has had menarche at 12 years age, last period on 14th August, regular cycles of 28 to 38 days. 28 to 30 days, bleeds for 4 to 5 days, and no complaint of pain or passage of clots. She's been married for 12 years, two babies, both delivered by normal vaginal delivery, and both children are healthy and attained all milestones according to age. So that completes our history of the patient. Now we'll start right from the beginning. So our patient is a young female, 36-year-old female. Now, usually, these cases, whenever a female, young age, or even middle aged comes to you with a swelling in front of the neck, based on the location and based on the most common swellings that happen, we usually suspect a thyroid swelling in this case. And we have seen that in case of thyroid swellings, these are more common in females than in males. So first, let's talk about why are thyroid swellings more common in females. So there are many reasons over here. The first one, the most important reason over here is the relation of estrogen and thyroid cells. Now, thyroid follicular cells, they have estrogen receptors as well, which is ER alpha and ER beta. Because of the presence of this estrogen receptors, now estrogen can actually come and bind over here and stimulate the thyroid cell proliferation. And this can promote the growth of nodules as well as tumor. Second is that estrogen itself also influences the expression of certain growth factors in the thyroid. What are these growth factors? EGFR and IGF-1. So these are the two reasons how estrogen, which we see only in females over here, is able to proliferate the thyroid follicular cells. Next point. Next point is the relation of pregnancy and reproductive hormones. Now, when a person is pregnant, during the time of pregnancy, we see a rise in estrogen as well as HCG. Now, both of this end up stimulating the thyroid gland. That is why sometimes you can see that we do end up seeing some thyroid abnormalities during the time of pregnancy. You can even have a physiological goiter during the time of pregnancy because of the rise of estrogen and HCG. And when you have had repeated pregnancies over a lifetime, all of that actually increase the cumulative thyroid stimulation that the person goes through. So that's about the pregnancy related thyroid swellings. Third point over here is the iodine requirement and deficiency. So women, especially during the time of pregnancy and lactation, they have much higher iodine requirements. So even if the dietary iodine is marginal, the women are actually more prone to develop goiter than men. So iodine requirement is again another feature over here, which is why we end up seeing more thyroid swellings in females. Last point over here is autoimmunity and a female immune bias towards it. We have seen that a lot of thyroid diseases are actually autoimmune in nature. For example, we have Hashimoto's thyroiditis, we have Graves' disease. We have seen that autoimmune diseases have been seen to be more common in women than in men. There is a ratio of 9:1 that is seen in case of Hashimoto's disease. How do you explain this? This is actually linked to X chromosome related immune regulation genes and sex hormones. That is the reason why we see more autoimmune diseases in females. So, these four reasons are the reasons why thyroid swellings are more common in female. The most important is the relation of estrogen and thyroid cells, because thyroid follicular cells have estrogen receptors on them. So, estrogen is able to stimulate the thyroid follicular cells. Second is pregnancy related rise of estrogen and HCG. Third is the iodine requirement and deficiency in females. And fourth is the autoimmune aspect. Moving on. So, our history over here, the main chief complaint is a swelling in front of the neck. So, that brings us to the question here, whenever a patient has come to you with a swelling in front of neck, or let's say a neck swelling, what are all the differential diagnoses that would come to your mind? Now, this can be either on the basis of what is the location of the swelling? Is it a midline swelling, or is it a lateral neck swelling, or is it a diffuse neck swelling? And the causes will vary. And the second way to know this is based on the type of cause. Is it a congenital cause? Is it an inflammatory cause? What are the inflammatory causes? What are the neoplastic causes? So let's discuss a little bit about the differential diagnosis. I'll definitely make a separate video on differential diagnosis of neck swelling where I'll discuss much more in details. But here first, let's know what are the options we have here. So first of all, let's discuss the differential diagnosis of neck swelling based on location. So we have either midline neck swelling, lateral neck swelling, or a diffuse neck swelling. What are some causes? Now, the most common cause of a midline neck swelling ends up being a thyroid swelling. Now, this can be either a goiter, it can be a thyroid nodule, it can be thyroid carcinoma. Next is a thyroglossal duct cyst. Now, this is seen in a much younger age group. So, usually, we'll not be suspecting it if a middle aged female comes to you with this. Other than this, it could be a dermoid cyst, or it could be a sebaceous cyst or lipoma if it is more superficial. Sebaceous cysts usually have a punctum on the skin. That's how it opens outside. So that could lead you to the diagnosis of sebaceous cyst. So these are all the DDs of midline neck swelling. Coming to lateral neck swelling, the most common cause of lateral neck swelling is a lymph node swelling. And even amongst that, the lymph node swelling, there could be various reasons for a lymph node swelling. It could be a reactive swelling, it could be a tubercular swelling, or it could also be because of metastasis over there. So these are all the causes of lymph node swelling. Other than this, lateral neck swelling could also be a branchial cyst or a fistula. It could be cystic hygroma, also known as lymphangioma. It can be a carotid body tumor, which is known as chemodectoma. It can also be a parotid gland swelling, which can be a benign tumor or a malignant tumor or even a case of infection. And it can also be a submandibular gland swelling, like in sialadenitis or a calculus formation in the gland, or a salivary gland tumor. So these are all the causes of lateral neck swelling. Next is diffuse neck swelling. Now, if we have a diffuse neck swelling, it is more likely to be some kind of an abscess, maybe. So, what are these deep neck abscesses that we can see? We can see a retropharyngeal abscess, we can see parapharyngeal abscess producing a diffuse neck swelling. We can even see a Ludwig's angina in this case. Other than this, even lymphangioma can also present as a diffuse neck swelling. So, these are all the causes of swelling in the neck based on its location. Next, let's talk about the differential diagnosis of swelling based on the cause. Now, there can be congenital causes, inflammatory or infective causes, neoplastic causes, vascular causes, and miscellaneous causes. So, coming to congenital, we have our thyroclossal duct cyst, branchial cleft cyst or fistula, amongst which second cleft is the most common one to be involved. We can have a dermoid cyst, which is typically a midline cyst that comes on. It can be a cystic hygroma, hemangioma, or a teratoma. These are all the congenital causes. Moving on to inflammatory or infective causes, most commonly it can be a reactive lymphadenitis or a tuberculous cervical lymphadenitis. It can also be because of some chronic granulomatous infections, for example, in sarcoidosis. It can also be a range of abscesses like some acute bacterial abscess or peritonsillar abscess, retropharyngeal abscess, parapharyngeal abscess, Ludwig's angina, or sialadenitis. These are all our inflammatory or infective causes. Next, we move on to neoplastic causes. Now, neoplastic causes can be divided into benign and malignant ones. Benign ones can be lipoma, fibroma, neurofibroma, pleomorphic adenoma, which can involve the parotid or the submandibular gland, or thyroid adenoma. And malignant causes most commonly can be lymphoma, which can be Hodgkin's or non Hodgkin's. There can be some metastatic lymph nodes coming from various of regions, like even ranging from the nasopharynx to involve the sinuses to other structures in the head and neck. Then it can be a thyroid carcinoma or salivary gland malignancies. Next, coming to vascular causes, we can have a carotid body tumor, also known as chemodectoma, carotid artery aneurysm, jugular venous dilatation, AV malformations, and hemangioma. These are our vascular causes. Last of all, coming to some miscellaneous causes like thyroid goiters, which can be a solitary nodule, which can be a multinodular nodule, can be a diffuse goiter as well. There can be a parathyroid adenoma and skin and soft tissue swellings like sebaceous cyst or epidermoid cyst. So, this is the differential diagnosis of neck swelling based on the type of cause. Moving on to our next point. So, we saw that the swelling was described as being very gradually, progressively increasing in size. So, there was an initial size of 2 into 2 centimeter, and since then, it has been gradually progressive. Let's talk about this progression in size and how the different ways in which it can progress can mean different diagnosis. So, in our case, we have seen that the patient has said there has been a gradual progression in size. That usually indicates towards a benign swelling. If the patient said that there was a rapid increase in size, by what do you mean by rapid increase in size? Meaning that there was a very rapid increase in size over the last maybe a few weeks, or maybe a month, or maybe 2 months, and the swelling was growing slowly, and then suddenly you see in a matter of a month or two, the size increases a lot. That indicates towards having a malignant transformation. A very close word, but very different here, is when there is a sudden increase in size. A sudden increase in size usually indicates that it happens over a period of a few days only. That one fine day, like the patient has been fine with a swelling for many years, and then suddenly one fine day they feel like that there has been a sudden increase in the size. That usually indicates towards having a hemorrhage in the nodule. So these are two very important MCQ points that you need to remember, as well as this is important for you to guide yourself in coming to a diagnosis when a patient complains to you with these things. So another thing to remember here is when there is a sudden appearance of a thyroid swelling and it is associated with pain, you should always suspect a case of thyroiditis over here. Okay, next moving on to all the negative history. Now, in our patient, all of these history has been negative. So let's see, in case one of these history was positive, what would it indicate towards? Starting with change in voice. Now, whenever there is a change in voice, the first thing you will suspect here is a case of recurrent laryngeal nerve palsy. Now, a sudden or progressive hoarseness in the thyroid swelling is a red flag for carcinoma of the thyroid. So, this is very important to remember. So, in a case of thyroid swelling, always look out for a history of change in voice or a hoarseness of the voice. Other than this, change in voice related to thyroid can be because of other causes as well. If the patient is hypothyroid, you can have change in voice because of edema of the vocal cord. Also, knowing about the change in voice preoperatively will alert the surgeon to a possibly pre existing recurrent laryngeal nerve palsy. This should be definitely documented because if there is a bilateral recurrent laryngeal nerve surgery injury during the time of surgery, it can lead to airway obstruction and stridor. So there's multiple levels of importance of knowing this history. Second is a history of pain and fever. Now, this will help you rule out cases like tubercular lymphadenitis, where you can see night sweats, we can see evening rise of temperature. Then, acute cervical lymphadenitis, abscesses like retropharyngeal abscess, parapharyngeal abscess, peritonsillar abscess, and Ludwig's angina. And this will also be seen in acute suppurative thyroiditis or de Quervain's thyroiditis. It can also be seen in salivary gland conditions like acute parotitis or acute submandibular sialadenitis, which can occur due to duct obstruction, jugular vein thrombophlebitis, and very rarely pain is a feature that you see in anaplastic thyroid carcinoma. Usually, all other thyroid swellings usually end up being painless, except for in cases of thyroiditis and in case of anaplastic thyroid carcinoma. Next is difficulty while swallowing, which is dysphagia. When can dysphagia happen in case of a thyroid swelling? There are two ways of this happening. First is if the esophagus gets compressed. Now, compression will happen when the thyroid swelling is very large. So, it can actually press on the esophagus and cause dysphagia. Second is if there is a malignant thyroid swelling and there is infiltration to involve the esophagus, that can also lead to dysphagia. Second is pain while swallowing, which is known as odynophagia. Now, pain while swallowing usually suggests a case of inflammation. This is one of the indications of it. And if it is an inflammation, it can be because of thyroiditis, where we see a painful tender swelling with fever and odynophagia. Secondly, it can also suggest malignant infiltration, and very rarely we can see it in cases of thyroid abscess or hemorrhage into a cyst. So, these are all the things you can find out by getting a history of odynophagia. Next is difficulty in breathing. Now, when will we have difficulty in breathing? There could be multiple reasons to it. The most common one is when the trachea gets compressed. So, when the trachea gets compressed, there is pressure atrophy and softening of the tracheal cartilages. This can happen in presence of a large multinodular goiter or a thyroid tumor. That can lead to difficulty in breathing. Second is when there is a tracheal deviation. How will this happen? This happens when the swelling of the thyroid is very large on one side and it pushes the trachea to other side. Third, it can also indicate tracheal infiltration, which can happen in case of anaplastic thyroid carcinoma. These are three ways by how you can end up having a history of difficulty in breathing. Next is if there is a retrosternal extension of goiter, meaning it has extended into the mediastinum, and there it can end up causing difficulty in breathing. We can also see difficulty in breathing in case of acute hemorrhage in a thyroid cyst or a nodule, which ends up enlarging the sudden increase in size. Other than this, other causes could be if the patient is a hypothyroid patient, they can also have difficulty in breathing, and the cause here would be because of respiratory muscle weakness and decreased respiratory drive. And on the other spectrum of it, if the patient is hypothyroid and has landed with thyrotoxicosis, you can end up developing congestive cardiac failure, and that can lead to difficulty in breathing. Lastly, very rarely, if there is a metastasis to lungs from a thyroid swelling, this can lead to difficulty in breathing. So, these are all the causes how a thyroid swelling can lead to difficulty in breathing, and what are the different things you should keep in mind. What a complication of a thyroid swelling over here. Next is patient has also complained of noisy breathing or stridor. Now, why will stridor happen? That can happen because of, again, first, tracheal compression by a large goiter, malignancy, or a retrosternal goiter. Second, it can be because of malignant infiltration of the trachea, which can be seen in anaplastic carcinoma. And third, stridor usually indicates an impending airway compromise. So, whenever the patient has come to you with stridor, you need to urgently evaluate the case, and sometimes you may also need to perform tracheostomy in the patient. So, this is the importance of taking the history of stridor in a patient of neck swelling. Next, we also took the history of palpitations and chest pain. Why is that important? If the patient has palpitation, this will usually suggest the presence of thyrotoxicosis. This is actually a red flag because if a thyrotoxicosis is untreated, it can actually precipitate the development of thyroid storm perioperatively. And where can you see this? This can be seen in a case of diffuse toxic goiter or Graves' disease or a toxic nodular goiter. So it is important to take a history of palpitations so as not to miss out the diagnosis of thyrotoxicosis in your patient before you take them off for surgery. Second, we also took the history of chest pain. Why is this important? So there are multiple reasons here. Three reasons are: it can be because of a cardiac cause, it can be because of some compressive symptoms, or it can be because of invasion by malignancy. Now, if it is the cardiac cause, it can be thyrotoxicosis related. So, in hyperthyroidism, what can happen is there is an increased myocardial oxygen demand, leading to angina in patients with underlying ischemic heart disease. So, this can end up precipitating arrhythmia or heart failure in patients. And that can lead to the chest pain as well as palpitations. Second is if there is any compressive symptoms. Now, this can happen in case of a retrosternal goiter. So, when there's a large retrosternal goiter, it can end up compressing the great vessels or other mediastinal structures. This can lead to the development of a sensation of tightness in the chest or some discomfort in the chest. And third reason could be if there is an advanced thyroid carcinoma, which is invading the mediastinum or the trachea. This can also rarely end up causing a chest pain. So these are the reasons for taking history of palpitations and chest pain. Next, let's talk about change in appetite and change in weight. These are very, very important features because these will help you. These are some features which will help you in deciding whether the patient is hypothyroid or hyperthyroid. First, let's talk about change in appetite. Now, where do we see an increased appetite? Usually, increased appetite will be seen in hyperthyroidism. Why? In hyperthyroidism, usually there is an increased metabolic demand. So, in this case, patient ends up eating more, but contradictory to this is you'll see that the patient is still losing weight despite having an increased appetite. And if there is a decreased appetite, it is seen in hypothyroidism. Now, in hypothyroidism, there's usually a lowered metabolic rate. So here, the digestion is sluggish, and patient can end up having anorexia a lot of the time. So this is how appetite can also point you towards the diagnosis of the clinical state of the thyroid. Next is change in weight. So very important MCQ questions over here to remember. First is if there is weight loss, despite a good or increased appetite, it is classically an indicator of hyperthyroidism or thyrotoxicosis due to an increased basal metabolic rate and catabolism. However, if you see a weight gain despite having a poor or decreased appetite, this is a feature of hypothyroidism due to decreased metabolism and fluid retention. Third, If there is no significant change in weight, this is often seen in benign euthyroid nodules, like in colloid goiter, for example. Another MCQ question over here to remember is if there is a history of loss of weight associated with a thyroid swelling, you should be suspecting hyperthyroid goiter rather than a case of thyroid malignancy. Now, we usually know that all malignancies are associated with weight loss. However, thyroid malignancies are usually not associated with that much of weight loss. So, if a thyroid swelling comes to you with loss of weight, the first thing you should remember is hyperthyroid goiter and not thyroid malignancy. Next is history of heat or cold intolerance. Now, heat intolerance is usually seen in a case of hyperthyroidism. Why so? So, in hyperthyroidism, we see an excess of T3, T4. So, therefore, this leads to an increased basal metabolic rate and increased heat production. Because of the increased heat production, there is also peripheral vasodilatation and sweating. So patient ends up feeling excessively hot. This will usually give you a clue towards a toxic thyroid swelling. Like for example, it could be a Graves' disease or toxic multinodular goiter or a toxic adenoma. Second, if there is cold intolerance. Now, cold intolerance is usually seen in hypothyroidism. How do you explain that? So, in hypothyroidism, we have a deficiency of thyroid hormone. So, there is decreased T3 and T4. This will lead to a reduced metabolic rate and reduced heat production. So, the patient will actually feel cold even in normal environment. This history will actually be a clue towards a hypothyroid state. Conditions like Hashimoto's thyroiditis or post-thyroidectomy or even post-radioiodine. Next, we also took a history of irritability, tremors in hand, and lethargy. Now, irritability is a feature of hyperthyroidism. Why do we see that? So, when there is an excess of thyroid hormone, they increase the sensitivity to catecholamines. That leads to nervousness, irritability, anxiety, and emotional liability. So these will be when you see irritability history is positive, that will be directing towards a clinically hyperthyroid state. Next, tremors in hand is also something that happens in the hyperthyroid state. Why does it happen? So, you'll be seeing, first of all, when you tell the patient to stretch out their arms with a sheet of paper on top, you'll see that the paper trembles. We see this fine, rapid tremors of the outstretched hands. Why does this happen? This occurs due to an increase in the sympathetic activity. This is a very strong pointer towards thyrotoxicosis. Third is lethargy. Now, irritability and tremor in hand were all features of hyperthyroidism. Lethargy, however, is a feature of hypothyroidism. Why so? So, in hypothyroidism, we have seen that there is a lower metabolic rate. This leads to a mental and physical slowing. So, the features you'll be seeing over here are fatigue, lethargy, excessive sleep, slow speech. So, these are all the features which will be pointing towards a hypothyroid goiter. Next is a history of double vision and bulging eyes. Now, why is this important to take in a case of thyroid swelling? So, double vision, also known as diplopia, we usually see this in cases of thyroid eye disease in Graves' disease. Why do we see it? It can occur because of extraocular muscle involvement, especially most common muscle to get involved here is the inferior rectus, and then is the superior rectus and medial rectus and levator muscle. This is the first reason for diplopia in case of thyroid disease. Second is there can be a fibrosis and restriction of movement, and this can lead to development of restrictive myopathy. The presence of double vision in these cases, they usually indicate towards active ophthalmopathy, which is very, very pathognomonic for Graves' disease. So, any kind of eye symptoms over here will directly point towards Graves' disease. Second, we also took the history of bulging eyes. Now, bulging eyes is either proptosis or exophthalmos, which we see in case of Graves' disease. Why does this occur? This occurs due to autoimmune inflammation, which leads to the deposition of glycosaminoglycans and edema in the retroorbital tissue and muscles, which can actually lead to forward protrusion of the eyeball, which is known as exophthalmos. There are other associated features in the eye as well with this, like lid lag, lid retraction, staring look, conjunctival chemosis, corneal exposure, and diplopia. So, these eye symptoms, whenever there is any kind of eye sign or complain of double vision or complain of bulging eyes, that will point you towards Graves' disease. Next is a history of change in bowel movement. So, if there is diarrhea, diarrhea is a very common feature of hyperthyroidism. So, in case of excess T3 and T4, as we already know, it leads to an increased metabolic rate. This will also lead to an increase in the gut motility, and this will lead to frequent loose stool and diarrhea. So, that is the reason for diarrhea in cases of hyperthyroidism. Whereas in cases of hypothyroidism, we see more complaints of constipation. Why? Because in hyperthyroidism there is sluggish intestinal peristalsis. This leads to the development of chronic constipation in the patient. So even the state of bowel movement can help you directing towards hypo or hyperthyroidism. Next is cough with hemoptysis. Now, there can be two reasons for this. One is if there is a local infiltration or compression. So, if we have a case of thyroid carcinoma, especially in cases of papillary carcinoma, they can end up invading, or anaplastic carcinoma. If they end up invading the trachea, it can lead to cough, hemoptysis, and even stridor sometimes. Second, if there is a retrosternal goiter. So, first is a case of thyroid carcinoma whereby infiltration it has invaded the trachea. Second is a case of retrosternal goiter, which can cause a tracheal irritation or compression leading to the production of cough. But usually, here hemoptysis does not occur. So, we'll only be seeing a complaint of cough without hemoptysis. Third is a case of lung metastasis. Now, follicular carcinoma of thyroid usually spreads by the hematogenous route. By the hematogenous route, it can end up reaching the lungs, causing cough, hemoptysis, and dyspnea. We know that follicular carcinoma spreads by the hematogenous route, whereas papillary carcinoma is more commonly spreading through the lymph nodes. So that's about cough with hemoptysis. Next, we also took a history of if there is any swelling elsewhere in the body. Now, when we ask about that history, what are these other locations we are talking about? First of all, is the location itself is in the neck. If there are any other swellings other than the swelling that the patient has come to you with, meaning, are we seeing any other lymph node swellings? Now, papillary carcinoma thyroid usually spreads early to cervical lymph nodes, usually the jugulo-digastric and jugulo-omohyoid lymph nodes. Second, medullary carcinoma of thyroid also has a lymph node spread, and sometimes even thyroid lymphoma also we can see in cases of Hashimoto's thyroiditis. So these are some of the reasons why there could be another lymph node swelling in the presence of this thyroid swelling. Second location would be to check for pulsatile bony swellings. Now, pulsatile bony swellings, this brings in an MCQ question. What are the conditions where you can see pulsatile bony metastasis? First, right over here, as we are talking about thyroid, is thyroid carcinoma, especially follicular carcinoma. We usually see pulsatile skull metastasis over here. And second is renal cell carcinoma. We also see pulsatile bony mets over here. And most commonly, flat bones are involved over here, like the skull, the ribs, the vertebra. So that's about the pulsatile bony swelling. Third is if there is any other swelling of other endocrine glands. Now we know that medullary carcinoma of thyroid is associated with a syndrome which is known as the MEN syndrome. Now MEN syndrome, you can find other masses like, for example, we can find pheochromocytoma, which is an adrenal mass, or we can have a parathyroid mass as well, like parathyroid adenoma. So these are some other masses in the body or swellings of other endocrine glands we should also check for to rule out all of these other like causes like presence of any other syndrome, presence of metastasis. Next, we also took a history of surgeries in the neck and radiation exposure. So, coming to surgery in the neck, why is it important to take a history of surgery in the neck in a case of thyroid swelling? First of all, if there has been a previous thyroid surgery, this can direct towards a recurrence. So it can either be a recurrent goiter which has come back after performing a subtotal thyroidectomy. And why does this recurrence happen? It can happen because of either incomplete excision or iodine deficiency or a multinodular disease. Second, if it has come back after a previous thyroid surgery of a malignancy, this will indicate towards development of a residual or recurrent carcinoma. So this is the importance of knowing if there has been a previous thyroid surgery or not. Second is if there has been a previous neck dissection or any lymph node surgery, that history will point towards a previous metastatic thyroid carcinoma or any other head and neck malignancy. Third is a parathyroid surgery, and this is important in cases of Men's syndrome because in Men's syndrome, we see that parathyroid adenomas or parathyroid hyperplasias are very common. So these are the reasons why you should also take a history of surgery in the neck. Next is radiation exposure. Now, why is this important? We know of some thyroid malignancies, which is the main risk factor over there could be an exposure to radiation. And that thyroid carcinoma is papillary thyroid carcinoma. So, this is a huge risk factor over here. So, what kind of radiation exposure are we talking about? Maybe there has been some childhood malignancy in the head and neck, or a case of lymphoma where they have been treated with radiation. Or you can if some person has undergone multiple CT scans of the head and neck, so that can also actually cumulatively add into the radiation exposure. And the most common carcinoma associated with this radiation exposure in the neck is the development of papillary thyroid carcinoma. Now let's move on to our past history and family history. So, in past history, we spoke about how we took a history that there is no history of intake of thyroid related medications. Why do we need to take this? And what are these thyroid related drugs we are talking about? So, coming to drug history related to thyroid, the common drug history that we should be taking is iodine containing drugs like amiodarone or iodine contrast media. There can be antithyroid drugs like carbimazole, propylthiouracil, and methimazole, thyroid drugs like levothyroxine, lithium, which is a mood stabilizer, interferons, and interleukin 2, and there are some other drugs as well. So, iodine containing drugs, the most common one is amiodarone. Now, amiodarone is very rich in iodine, and this can end up in causing either amiodarone induced thyrotoxicosis or amiodarone induced hypothyroidism. It produces thyroid enlargement or nodules. And second is a history of taking iodine or iodinated contrast media, because that can lead to Jod based phenomena, which is iodine induced thyrotoxicosis, especially in cases of nodular goiter, or a Wolff Shakeoff effect, which leads to hypothyroidism. So these are the importance of taking the history of iodine containing drugs. Next is antithyroid drugs like carbimazole, propylthiouracil, and methimazole. These are usually used for hypothyroidism treatment, and the history will help you in knowing whether the patient has been on any kind of treatment for thyroid disease or not. And levothyroxine is a drug which we used in hypothyroidism or in post-thyroidectomy patient to replace the thyroid hormone. Third is lithium. Now, lithium, it has a mechanism of action where it interferes with thyroid hormone release. So, take intake of lithium in these patients, you can see goiter and hypothyroidism as well. So, it is important to take a history of lithium intake in these patients. Next is interferons alpha and beta and interleukin 2, which can induce autoimmune thyroiditis leading to hypo or hyperthyroidism. Other drugs that you may ask about as well, but not commonly used, are tyrosine kinase inhibitors like sunitinib and sorafenib, immunotherapy like nivolumab and pembrolizumab, which is used in autoimmune thyroid, which can cause autoimmune thyroiditis, and glucocorticoids or dopamine agonists, which can suppress TSH and mask the thyroid status. So these are all the thyroid containing drug history that you should be thyroid related drug history that you should be taking from your patient. Next, why is family history important? We asked about if there is any similar incidents in the family, or is there any cancer or cancer related deaths in the family. This is important because of the case of MEN syndrome. We know that medullary thyroid carcinoma is associated with MEN2 syndrome. So amongst that, one of the features of MEN2 syndrome over here is pheochromocytoma. Now, pheochromocytoma, if it is untreated, it can lead to sudden death because of hypertensive crisis, arrhythmia, stroke, myocardial infarction, and catecholamine-induced cardiomyopathy. So these are the reasons why pheochromocytoma can lead to a death. Now, in MEN2A and MEN2B, they classically have pheochromocytoma, a medullary thyroid carcinoma, and a parathyroid hyperplasia. So here, the pheochromocytoma component is a dangerous component which can end up killing the patient if you have missed it before performing a thyroid surgery. Now, that's why we should know if there is any such cancer-related deaths in the family. So, in case of men, the first priority is always to rule out pheochromocytoma before you take the patient up for any surgery for the thyroid or parathyroid, because a case of undiagnosed pheochromocytoma can lead to an intraoperative hypertensive crisis leading to a sudden death. And that's why family history is important. Next, let's talk about what are the features that we see in MEN syndrome and what are the genes that is involved in it. So MEN syndrome can be MEN1, MEN2. MEN2 can be divided into MEN2A, MEN2B, and MEN4. Now, MEN1 is also known as Werner's syndrome. Here, MEN1 gene is involved. How to remember what are the features in it? Remember the mnemonic 3P. So with 3P, we have parathyroid hyperplasia, pancreatic tumors, and pituitary adenoma. Amongst the pituitary adenoma, prolactinoma is the most common one. And the most common presentation in men 1 is usually a hyperparathyroidism seen in 90% cases. And pancreatic tumors here often end up being malignant and the main cause of death in case of MEN1 syndrome. Next is MEN2. MEN2A is Sippel syndrome. Here, the red proto-oncogene is involved. How do we remember this? The mnemonic is 1M plus 2P. So with M, we have medullary thyroid carcinoma, and with 2P, we have pheochromocytoma and parathyroid hyperplasia. Out of these, the most dangerous one is that of pheochromocytoma when it is untreated, or even if medullary carcinoma is untreated, death can happen from there. And in cases of RET gene carriers, usually a prophylactic thyroidectomy is advised. This is about MEN2A. Then is MEN2B, where again the gene involved is red proto-oncogene. But here the mnemonic is opposite to that of MEN2A. Here it is 2M and 1P. So 2M is medullary thyroid carcinoma, mucosal neuroma and marfanoid habitus, and with P we have pheochromocytoma. So we see that medullary thyroid carcinoma and pheochromocytoma are common features in MEN2A and MEN2B. And MEN2B is the most aggressive type of MEN syndrome, and here death can occur from aggressive medullary thyroid carcinoma or pheochromocytoma crisis. Lastly is MEN4, which we do not have to know that much about. For us, more important is to look at MEN2A and MEN2B. But MEN4, the gene involved is CDKN1B gene. This is similar to MEN1 features, where we see parathyroid tumors, pituitary adenoma, and along with that, you also see adrenal, gonadal, and kidney tumors. This is usually a rarer MEN syndrome, and the cause of death is usually pancreatic or neuroendocrine tumors. So, this is in short the features that you need to know about MEN syndrome. What is the other names of it? What is the gene involved? And what are the main features and causes of death? Now let's move on to menstrual and obstetric history. Why did we have to take that in a case of thyroid swelling? That's because in hyperthyroidism and hypothyroidism, the menstrual history is affected. So usually in hyperthyroidism, we see oligomenorrhea or amenorrhea. And in hypothyroidism, there's risk of menorrhagia, increased risk of miscarriage, preterm delivery, stillbirth, low birth weight, prolonged labor, or difficult deliveries. These are all the features that we see in hypothyroidism. Now, next we need to know, okay, why do we see amenorrhea in hyperthyroidism whereas menorrhagia in hypothyroidism? So, the causes of amenorrhea and hyperthyroidism, there are three such causes. One is in hyperthyroidism, we see an increased hepatic synthesis of sex hormone binding globulin. This sex hormone binding globulin goes and binds to the free estradiol and testosterone. and therefore it ends up lowering the biologically active free sex steroids, because of which leads to menstrual irregularities and amenorrhea. So this was our first reason. Second is, when in hyperthyroidism, because of the excess thyroid hormone, we have an altered estrogen progesterone balance. This occurs because of the disturbed LH FSH rhythm. So ovulatory cycles get suppressed and leading to anovulation, and in anovulation you end up having irregular or absent periods. Third reason is the direct effect on the hypothalamic pituitary axis. So when there's increased T3 T4, it does a negative feedback and it alters the GnRH and the gonadotropin secretion. This leads to disrupted menstrual cycle regulation. So because of these three reasons, we usually see oligomenorrhea or amenorrhea in hyperthyroidism. Whereas in hypothyroidism, we see more of menorrhagia. Why does that happen? So, in hypothyroidism, first of all, because of reduced T3 T4, we see an increased TRH. This leads to increased TSH and as well as prolactin. So, when there is increased prolactin, it inhibits the LH surge, leading to anovulatory cycles. And in anovulation, there is a continuous estrogen stimulation without progesterone opposition, and this leads to endometrium growing more, leading to heavy irregular bleeding. So, the main reason here is because of the hormonal imbalance due to increased prolactin and reduced LH surge. Second is, in hypothyroidism, we have an altered estrogen metabolism. Here, there is a reduced clearance of estrogen leading to a hyperestrogenic state. Because of the hyperestrogenic state, you end up with endometrial hyperplasia and excessive bleeding. Third is coagulation defects. Now, coagulation defects in hypothyroidism, we see reduced coagulation factor synthesis, and sometimes you can even see acquired von Willebrand disease. But that is more rarer. So, because of the reduced coagulation factor, it leads to excessive menstrual bleeding. Last of all is mixed edematous changes. Here we can see tissue edema. It can end up impairing the uterine contractility and hemostasis after shedding, leading to more blood loss. These are the four reasons why you see menorrhagia in hypothyroidism. So now that we have spoken a lot of features that we see in hypo as well as hyperthyroidism throughout from starting from the history, let's just have a table where we can know what are all the different systems affected in hypo and hyperthyroidism and what are the main features that you see. So coming to hypothyroidism, let's talk about general features first. So in hypothyroidism, I have already explained the patient has fatigue, lethargy, excessive sleepiness, weight gain despite poor appetite, intolerance to cold, puffy face, and generalized swelling. When the cardiovascular system symptoms are bradycardia, reduced exercise tolerance, breathlessness, pericardial effusion, dyspnea. Neuropsychiatric symptoms would be slowness of thought and action, poor memory, difficulty in concentrating, depression, which can actually mimic dementia in the elderly, and this is known as myxedema madness. Coming to gastrointestinal symptoms, hypothyroid patients have constipation, anorexia, and abdominal distension. Coming to skin and hair, they usually have dry, coarse, cold skin, hair loss, thinning of lateral eyebrows, which is also known as madarosis. This is also known as Queen Anne sign. They also have brittle nails, pallor, or yellowish tinge on them, which is known as carotenemia. Coming to reproductive system, we just discussed that these patients more commonly have menorrhagia, but sometimes they can even have oligomenorrhea or amenorrhea. Infertility, increased risk of miscarriage, preterm delivery, stillbirth, low birth weight, prolonged labor or difficult delivery, and in cases of children, delayed puberty. Next is musculoskeletal system. They usually have muscle cramps, stiffness, myopathy, and arthralgia. And other miscellaneous symptoms could be hoarseness of voice. We just discussed it because of edematous larynx, thickened cords, hearing impairment, puffy hands and feet, enlarged tongue, slow, deep voice, and carpal tunnel syndrome. So, these are all the features that you see in a case of hypothyroid patient. Next is hypothyroid patient. They usually have important feature here is they have weight loss despite having an increased appetite, heat intolerance, excessive sweating, fatigue, muscle weakness, tremors in their hand, decreased sleep. Coming to cardiovascular symptoms, they have palpitations, breathlessness on exertion, increased systolic blood pressure, and very important that you end up noticing clinically is a collapsing pulse, which happens because of wide pulse pressure. Because the systolic pressure increases, the diastolic doesn't increase as much. Therefore, the pulse pressure ends up being wider, leading to development of a collapsing pulse. Neuropsychiatric symptoms include irritability, nervousness, anxiety, emotional lability, restlessness, insomnia, tremors of the hand, and hyperreflexia. Coming to gastrointestinal symptoms, sometimes there is increased frequency of stool or even diarrhea, increased appetite, and rarely vomiting. Skin is usually warm, moist, and velvety. Hair is fine and thin. There can be diffuse hair loss, flushing, palmar erythema, onycholysis, which is also known as plumber's nails. This is also an important MCQ. Next is the eye signs. Again, that is something we'll have to learn separately in another class. But typically, patients have photophobia, prominent eyes, which is known as exophthalmos, lid lag, lid retraction, double vision because of extraocular muscle involvement. Reproductive system is involved, and in that case, you end up seeing oligomenorrhea or amenorrhea and infertility. In men, you can see gynecomastia and loss of libido. Musculoskeletal system, usually there can be a proximal muscle weakness. So the patient may complain of difficulty in climbing stairs or combing hair. And there can be myopathy. Other than this, there's increased thirst, polyuria, pretibial myxedema, thyroid acropathy. So these are all the features of hyperthyroidism. So these two tables are two tables that you need to understand, and you have to understand every reason behind each of these features. I'll make a separate video on both of these soon. Okay, let's move on to the next part. Now, we know two terms as hyperthyroidism and thyrotoxicosis. What do they mean? Are they the same thing? Are they the same condition? Let's find out a little bit more. So, hyperthyroidism is a condition where the thyroid gland itself is overactive. So, therefore, it leads to production of excess thyroid hormones. Hyperthyroidism can end up causing thyrotoxicosis. Whereas thyrotoxicosis is a clinical syndrome which occurs due to the presence of excess thyroid hormone in the blood. But however, the source does not necessarily have to be thyroid. It is just a clinical syndrome that happens because of excessive thyroid hormone in the blood. Now, causes of thyrotoxicosis can be multiple. So, hyperthyroidism definitely is the most common cause which causes thyrotoxicosis, but could also be because of thyroiditis, where there is release of preformed hormones, and here the gland is not overactive. Or there can be exogenous thyroid hormone intake, like in factitious thyrotoxicosis, or in case of struma ovari, where the ovarian teratoma has thyroid tissue, or if there is any thyroid hormone secreting metastasis. So, what did we learn here? That all cases of hyperthyroidism, can cause thyrotoxicosis. However, all thyrotoxicosis cases are not because of hyperthyroidism. It can happen because of any other reasons mentioned over here. The main thing in thyrotoxicosis is it happens because of excess thyroid hormone. That's all about our history discussion. Now let's move on to general examination and clinical examination. So, in the general examination, I'll just skip over because there was nothing significant found here. Even the systemic examination was normal. Let's move on to local examination of the neck. So, on inspection, inspection is usually done when patient is in sitting position with neck slightly extended. What we saw here is a single swelling in the anterior aspect of the neck and midline, globular in shape, 4 into 4 centimeter size, extending from thyroid below the thyroid cartilage to 2 centimeter above the sternal notch vertically, and 2 centimeter from anterior border of right sternocleidomastoid to anterior border of left sternocleidomastoid horizontally. It has well-defined margins and smooth surface. Swelling moves with deglutition but does not move on protrusion of tongue. The skin of the swelling appears normal. There are no scar, sinus, engorged vein, or visible pulsation. Trachea is in midline, no other visible swelling in the neck, and Pemberton sign is negative. Next, coming to palpation. So, how do you palpate? The patient is examined in the sitting position with their neck flexed, and you will be standing behind the patient. So here again, the single swelling is felt in the anterior aspect of the neck and midline. Same things, the extent is the same. There is no local rise of temperature over swelling, not tender to touch. Skin over swelling is pinchable. All the borders are well defined. Lower border is palpable. Smooth surface, firm consistency. It is mobile in both horizontal and vertical planes. And on percussion, a resonant sound is heard over the manubrium sterni on direct percussion over there. And on auscultation, there is no bruit audible. The carotid artery is palpable bilaterally and neck nodes are not palpable. Rest all other examination is normal. So that's our clinical examination of the patient. Now let's discuss a few points that we have studied here. So first of all, we have noted that there's a single swelling. We have seen it in the anterior aspect of the neck. And we have noted the extent of the swelling. It has well-defined margins and smooth surface. Next important point here is that the swelling moves with deglutition but does not move on protrusion of the tongue. What does this mean and what do we infer from here? So what are some swellings which move with deglutition and what are some swellings which move with protrusion of the tongue? So typically swellings that move with deglutition can be a thyroid swelling, thyroglossal duct cyst, subhyoid bursitis, laryngeal swellings because the larynx moves with deglutition, and pretracheal lymph nodes secondarily adherent to thyroid or larynx. What is the reason behind all of these swellings moving with deglutition? So swelling, which is attached to pretracheal fascia, larynx, or the thyroid gland, they move up and down during the during swallowing because of the attachment of the fascia. Whereas there's only one swelling that we know that moves with protrusion of the tongue. That is thyroglossal duct cyst. This is the only classical swelling that we know. The swelling here is attached to the foramen cecum via the thyroglossal tract, and the tongue movement pulls the cyst upward. So, very important to remember here. Here we found out that the swelling does not move with protrusion of the tongue, so it definitely rules out thyroglossal duct cyst. However, it moves with deglutition, so pointing more towards the involvement of the thyroid gland. So important, no 2 points here is if a swelling moves with deglutition only, you should think of thyroid, laryngeal or pretracheal lesion. Whereas if a swelling moves with both deglutition and tongue protrusion, it is definitely a thyroglossal duct cyst. Next, let's talk about some thyroid swellings which actually don't move with deglutition. What are some possible scenarios? One is in case of advanced thyroid carcinoma and anaplastic carcinoma. So here, why will it not move with deglutition? When malignant infiltration may end up fixing the gland to the surrounding tissue like the strap muscles, trachea and esophagus. This will lead to loss of mobility and hence, this thyroid swelling will not move with deglutition. Second such scenario is a thyroiditis with fibrosis, like in Riddle's thyroiditis and chronic thyroiditis, where dense fibrosis may end up fixing the thyroid to the surrounding structure, which is why it will not move with swallowing. So, these are two such scenarios where thyroid swelling will not move with swallowing. Okay, next point. We have also discussed that the skin over the swelling is normal and there is no scar, sinus, engorged vein, or visible pulsation. So, if we did see any visible pulsation or engorged veins, what would it indicate? So, if there were visible pulsations on the thyroid swelling, this is usually seen in highly vascular thyroid swellings like Graves' disease and second, thyroid malignancy with vascular invasion. So, Graves' disease is more common And in Graves' disease, there is marked vascularity due to the hyperfunction of the thyroid. So you end up seeing visible pulsation over the swelling, and when you auscultate, you also hear a bruit. And even in cases of thyroid malignancy with vascular invasion, but this is this is less likely to happen than Graves' disease. Why do we see the visible pulsation? When there is an increased arterial blood flow, it transmits the pulsation to the surface, and enlarged thyroid arteries can be seen visibly pulsating very easily. So, this is your inference if you do end up seeing a visible pulsation on top of the thyroid swelling. Next is engorged veins in thyroid swelling. If you see in the image over here, we can see some engorged veins over here. Which condition do we usually see it in? We can see this in retrosternal or intrathoracic goiter. Why? Because a retrosternal goiter, what happens is the swelling extends into the thoracic inlet. And once it has gone into the thoracic inlet, it can end up compressing the great veins, which is the innominate vein or the superior vena cava. This will cause venous engorgement over the upper chest, neck, and face. So this is why we end up seeing engorged veins and retrosternal goiter. So clinical picture will look like that of a superior vena cava syndrome, where we see dilated tortuous neck vein, facial congestion, puffiness, cyanosis, and symptoms which worsen on bending forward or raising arms, which is Pemberton sign positive. That brings us to the question, what is Pemberton sign? Now, Pemberton sign is very important to remember here. It is a clinical marker that is used in the detection of thoracic outlet syndrome, specifically in cases of superior vena cava obstruction. How do we elicit the Pemberton sign? We'll ask the patient to raise both their arms. You can see in this image that they have raised both their arms straight up beside their ear, and you'll hold it over there for 30 to 60 seconds. At this time, you will be noticing for facial flushing or plethora, neck vein distension, stridor or dyspnea, and even syncope can occur in severe cases. You can see this person over here. The first image is when the arms are not raised. You can see how the face appears normal, but on raising the arms, you can see how flushed the face appears. This is known as Pemberton sign positive. And where will you see this? This is usually most classically seen in retrosternal goiter or intrathoracic goiter. Any mass at the thoracic inlet like mediastinal mass, lymphoma, thymoma, which is causing an obstruction of the superior vena cava, and occasionally a large cervical goiter extending downwards. Now, Pemberton sign positive, we just discussed what is it. Now, what is the mechanism behind this sign? So, in patients who have a large retrosternal goiter, the thyroid extends into the thoracic inlet. So, raising both the arms above the head, what will it cause? First of all, the elevation of the clavicle and the first rib will happen. This will end up narrowing the thoracic inlet. So, now the retrosternal thyroid mass will get trapped or compressed between the sternum and the spine. This will cause a compression of the superior vena cava and the trachea, leading to all the features that you just saw of facial congestion, neck vein distension, and even dyspnea. So that's about the Pemberton sign. What is it? Where do you see it? And how do you perform it? And what is the mechanism behind it? Next question is, why do thyroid swellings tend to grow downwards rather than upwards? That answer can be derived from the anatomical attachment of the capsule of the thyroid gland. So, for more details, you can refer to my video on the anatomy of the thyroid gland. But let's talk in short over here. So, we know that the thyroid gland is actually enveloped by the pretracheal layer of the deep cervical fascia, which forms the false capsule of the thyroid gland. This fascia, when it goes upwards, its superior attachment is to the oblique line of the thyroid cartilage and the hyoid bone. Because of this strong attachment over here, the thyroid gland cannot extend upwards beyond this level. Secondly, the thyroid is again covered by pretracheal fascia, but in the inferior aspect, it is much relatively loose and thin. So therefore, there will be less resistance to a downward extension. And third reason is the space in the thoracic inlet. So the thoracic inlet and the superior mediastinum, they are actually providing a potential space into which the thyroid can expand. Compared to the region above, there's way fewer anatomical barriers in the inferior aspect. So these are the reasons why you'll see a thyroid swelling is more likely to extend downwards rather than upwards. Okay, next coming to palpatory findings. We saw a lot of palpatory findings over here. So, before we discuss that, let's talk about what are the different methods that we know when it comes to thyroid palpation. First one is Kreil's method. When do we use it? Usually, this is done when you get a solitary thyroid nodule case. How do you perform it? We place a thumb on the thyroid and ask the patient to swallow, and then you feel the gland's movement. This method is very helpful in detecting small nodules within the thyroid gland. So, whenever a solitary thyroid nodule case comes to you where the nodule is very small, Kreil's method helps you in palpating it better. Next method is Lahey's method. Now, here in Lahey's method, again, it is important for detecting nodules. Here, we tell the patient to sit with their neck slightly flexed forward so that the strap muscles get relaxed. You stand in front of the patient or behind, and in front of the patient, and you end up displacing the trachea and the thyroid lobe to one side. You see in the image over here, you displace the thyroid lobe and the trachea to one side with one hand, and then you palpate the opposite lobe with the other hand. So you can see how you're palpating over here. The use of this method is that it helps you in palpating each thyroid lobe for detecting nodules. This is the second image demonstrating the same Lahey's method. Third method is known as Pizzillo method. This is also very important from your clinical examination perspective, because here, when a obese patient comes to you or a patient who has a very short neck, this method will help you in examining those patients. So you ask the patient to lie in the supine position with the neck hyperextended and shoulders elevated. So they place their arms like this over here, and usually a pillow is placed under the shoulder. Here, the use of this method is that when you do this, this movement makes the thyroid appear more superficial and makes it more prominent. So it becomes helpful in case of obese patients and shocked neck patients. Last method is the Cocker's method. Now, Cocker's method is a method that you use for palpating the thyroid gland, especially in case of diffuse goiter. How do you do it? The examiner will stand behind the patient and palpate both the lobes simultaneously with fingers while the thumbs steady down the trachea. That's how you do the Cocker's method. So that's about the 4 methods of thyroid palpation that we have learned over here. Next is there's a very famous Viva question, which is what is thyroid paradox? Now, thyroid paradox here, usually, what do we know about palpating a benign and a malignant swelling? So, when you palpate a benign swelling, usually they are about soft to firm, whereas malignant swellings are usually hard in consistency, right? But the paradox over here is sometimes a benign thyroid swelling can feel hard. For example, if there is, say, a tense cystic swelling or fibrosis or hemorrhage or calcification within the swelling. Whereas sometimes a malignant thyroid swelling can end up feeling soft, because this can happen in cases of hemorrhage or necrosis in the tumor. So, this is what the thyroid paradox is. It refers to the fact that in thyroid, benign nodules may feel hard due to fibrosis, calcification, etc., while malignant tumors may end up feeling soft to firm, unlike in most other organs, where usually hardness indicates malignancy. So that's about thyroid paradox, which is a very important Viva question. Next, let's talk about percussion and auscultation. Now, what is the reason that we are percussing in case of this thyroid swelling? So, we do a direct percussion over the manubrium sterni over here. And when you hear a resonant sound, what does it indicate? It suggests the presence of air containing structures like trachea, lungs are directly behind the manubrium, with no retrosternal mass obstructing them. So, in our case, we got a resonant sound. So, that means our thyroid swelling does not have any retrosternal extension. However, if we had a retrosternal goiter present, in that case, percussion would over the manubrium would have been dull. That means the mass would be present behind the manubrium sterni. And this is the importance of performing percussion in these cases. Next is auscultation. So in thyroid examination, sometimes you can hear a bruit. What is a bruit? Is this whooshing vascular sound that you hear when you auscultate over the thyroid gland. This is usually seen in hypervascular conditions like in Graves' disease or thyroid malignancy with high vascularity. And when there is no bruit, which is what we saw in our case, what is the interpretation that we draw from it? So absence of bruit means the swelling is not hypervascular and it is less likely to be a Graves' disease swelling, more likely to be a simple benign thyroid swelling. Now, we spoke about that, okay, we may hear a bruit, but for that we need to know where should you auscultate for this bruit and why. So the area that we auscultate for the bruit for is over the upper pole of the thyroid swelling on either side. Usually we ask the patient to hold their breath to avoid any transmitted breath sounds that may come from it. So, uh, so we have realized that we are auscultating for bruit at the upper pole of the thyroid swelling. What is the reason why we are doing it at the upper pole and not at the lower pole? First reason is the arterial supply. So we know the two main arteries that are supplying are the superior thyroid artery and the inferior thyroid artery. So superior thyroid artery is a dominant artery in case of hypervascular states like Graves' disease. It enters the thyroid at the upper pole. So any turbulence of the increased blood flow will be maximal and best transmitted at the upper pole. Here, basically, superior thyroid artery enters as a single high flow vessel. The problem with lower pole and the inferior thyroid artery is that the inferior thyroid artery enters at the lower pole, but then it ends up dividing into several more branches before it reaches the gland. So it ends up spreading out the flow. This makes the turbulence less focused over here, and so therefore it is harder to auscultate at the lower pole to get a bruit. Next question is, what is Berry's sign? A Berry's sign is when the carotid artery is not palpable at its location. What are the possible reasons for it? One is when there is a large benign thyroid swelling and it is displacing the carotid sheet and its contents posteriorly. Second is a malignant thyroid swelling which has infiltrated and encased the carotid sheet. These are two different ways by which two different types of swelling can end up leading to non-palpable carotid artery, which is Berry's sign. Now let's summarize our case. So we have a 36-year-old female whose main complaint has been swelling in front of the neck since 3 years, which has been gradually progressive. And on examination, we found a single non-tender swelling, anterior aspect of the neck in midline, moving with deglutition but not moving on protrusion of tongue, globular in shape, 4 into 4 centimeter size. Extent I've already mentioned. There's no local rise of temperature. Skin over swelling is pinchable. All borders are well defined. Lower border is palpable. There's a smooth surface, firm consistency, mobile. Percussion, there's a resonant sound. And on auscultation, there is no bruit. Okay, now that we have summarized our case, let's talk about what is a provisional diagnosis. So, a provisional diagnosis over here is solitary thyroid nodule involving the left lobe, probably benign in clinically euthyroid state. So, that is our provisional diagnosis. So, essentially, the next question would be, what are the points in favor of this provisional diagnosis? Let's discuss that. So, right from the history, we have a young female, 36-year-old female, who has presented with a midline neck swelling, anterior neck location. Both of these factors typical site for thyroid swelling. That's what it is indicating over here. Then the swelling moves with deglutition, so it confirms that the swelling is thyroid in origin. But the swelling does not move with tongue protrusion, so it definitely rules out thyroglossal duct cyst. It has well defined borders, smooth surface, firm consistency, non tender, and skin is pinchable. These are all benign characteristics. So far, we have not seen any malignant characteristics. Also, according to the history, this is a very insidious, slowly progressive course that the swelling has taken, and there are no signs of metastasis. So, it is definitely more likely to be benign rather than malignant. The lower border is palpable, so it's definitely not a retrosternal goiter. And there is no bruit heard. So, absence of bruit suggests that this is definitely not a toxic goiter or Graves' disease. So, all of these features together, it supports that this is possibly a benign thyroid swelling. And since we have examined and found only a solitary thyroid nodule, so we say that this is a solitary thyroid nodule involving the left lobe, probably benign. And because we have not seen any hypothyroid or hyperthyroid features, it is in a clinically euthyroid state. So, these are all the points that have led to our diagnosis. So, when we are making the diagnosis, there are 4 points over here that we need to remember. We need to remember the anatomical location of the swelling. Where is the swelling originated? So in our case, this is a it has originated in the thyroid gland. Then when you know that this is the thyroid gland, you have to find out what is the physiological state that the patient is in. Is the patient euthyroid, hypothyroid, or hyperthyroid? Third is, do you feel that the swelling is benign or malignant, depending on the history and the clinical examination that you have done? Last of all, if there is any complications or not, like for example, say compressive symptoms like dysphagia or dyspnea or hoarseness of voice. So these are all the points that you should be looking for before you make your provisional diagnosis. So now that we're done with this, we know that our case is that of a solitary thyroid nodule. Let's talk about what is a differential diagnosis of a solitary thyroid nodule. So I've just listed down the causes over here. I'll make a separate video where I talk more about in details about the following. So we can divide them into, first of all, we have benign thyroid lesions. And the most common benign thyroid lesion is a colloid nodule. So it is a colloid goiter. Usually, they are slow growing, smooth, firm in consistency, and usually asymptomatic, not causing any compressive symptoms, etc., to the patient. Second option is a follicular adenoma. These are encapsulated benign tumors, but it is very hard to distinguish it from follicular carcinoma on an FNSC only. So, in that case, when you are not able to find out whether this is a follicular adenoma or a follicular carcinoma, you have to be more on the safe side and perform a total thyroidectomy, or you can even perform a hemithyroidectomy and send it for frozen section. And once it's confirmed it is follicular carcinoma, perform a total thyroidectomy. Third is, it can be a simple cyst or a hemorrhagic cyst, which can arise from degeneration of a nodule. So these are the options under benign thyroid lesions. Next is, it could also be a malignant thyroid lesion. So typical features of malignant thyroid lesion would be that it is irregular surface, it is fixed to the structure, or there's a rapid increase in size, or there is complaint of pain or other pressure symptoms. Pressure symptoms, however, is not definitely directed towards malignancy, but pressure symptom can also be caused by a very large goiter as well. Amongst malignant thyroid lesions, histopathologically, it can be a lot of things, like it can be papillary thyroid carcinoma. Now, papillary thyroid carcinoma is the most common thyroid malignancy, which presents as a solitary thyroid nodule. And papillary thyroid carcinoma is also the thyroid cancer which has the best prognosis out of all, usually seen in middle aged females, and it spreads by cervical lymph node metastasis. Second is our follicular carcinoma. Now, follicular carcinoma is also a well differentiated thyroid cancer. Usually, it is a solitary encapsulated nodule, and this carcinoma is notorious for hematogenous spread. Next is medullary carcinoma. Now, medullary carcinoma can also present as a solitary thyroid nodule, and it is associated with MEN2 syndrome, MEN2A and MEN2B. We already discussed how MEN2A and what are the features in MEN2A and MEN2B. Next is anaplastic carcinoma. Now, this is a rarer carcinoma, but however, if it does occur, it is very, very aggressive, and it usually ends up being a rapidly enlarging hard fixed swelling. This is also very notorious for infiltrating the surrounding structures as well, leading to fixity. Malignant thyroid lesion can also be a thyroid lymphoma. which is usually a firm to hard, rapidly growing thyroid swelling, often in the background of Hashimoto's thyroiditis. So these are our malignant thyroid lesions, which can present as a solitary thyroid nodule. Next broad heading would be other thyroid related nodules. For example, it could be a dominant nodule in a multinodular goiter case. We'll discuss in a little bit what do you mean by a dominant nodule. Second, it could also be a case of Hashimoto's thyroiditis. Now, Hashimoto thyroiditis usually is like diffuse form bosselated goiter, but in some cases, you may see that there is a focal lymphocytic infiltration combined with fibrosis, which leads to the formation of a localized hard nodule. Now, this can mimic the presence of a solitary thyroid nodule. This nodule, if it is formed, is known as a pseudonodule. Third, it can also be a subacute granulomatous thyroiditis like D. Quervain's thyroiditis. Classically, in D. Quervain's, we get a painful diffuse thyroid swelling post-viral. Rarely, however, this inflammation can be very localized and present as a tender solitary nodule. So, whenever a clinical clue towards the diagnosis of D. Quervain's could be when you find a painful nodule with a raised ESR, which is indicative of inflammation. So these are all the other thyroid related nodules that you can see. Last of all is non-thyroidal lesions which are mimicking solitary thyroid nodule. It can be a thyroglossal duct cyst. Usually this is in the midline and it moves with tongue protrusion, and it is only seen in younger people. Second, it could be a dermoid cyst or an epidermoid cyst. These are again midline swellings which are subcutaneous and does not move with deglutition. Third, it could be a lymph node swelling, could be like a jugulodigastric or a pretracheal node swelling. And fourth, it could also be parathyroid adenoma. However, this is very rare and this can end up mimicking a thyroid nodule. So these are all the differential diagnoses that we have of a solitary thyroid nodule. These are all things that should come to your mind when you have gotten a case of solitary thyroid nodule. Now, I asked just before, like, what is dominant nodule in a case of multinodular goiter? We know that multinodular goiter, the very term states the fact that there are multiple nodules that you feel when you palpate it. So, what is a dominant nodule here? So, the dominant nodule is a single nodule within the multinodular goiter that is larger than all the surrounding nodules, and it is clinically more prominent, and it may or may not feel different in consistency. It can be harder, irregular, or rapidly growing compared to the other nodules that are around it. So, what is the importance of finding out which is the dominant nodule? That's because in a case of multinodular goiter, most of the times the nodules are benign, but amongst all of them, the dominant nodule is the one which carries the highest risk of malignancy. So it may have a malignant transformation later. About 10 to 20% of dominant nodules have been seen to be turning malignant. In these cases, whenever you find a case of multinodular goiter with a dominant nodule, FNSE should be performed from this dominant nodule. So that's about the dominant nodule. Next, another viva question that may come to you is, what is lateral aberrant thyroid? Now, this is actually a misnomer. What lateral aberrant thyroid is actually it's a metastatic deposit that happens from papillary thyroid carcinoma in a cervical lymph node. So earlier, lateral aberrant thyroid were described as the presence of this ectopic thyroid tissue, but that is actually not true. It is actually a metastatic deposit of papillary thyroid cancer in a cervical lymph node. It is not a true ectopic thyroid tissue. So at any point of time, if you end up seeing thyroid tissue in the lateral neck, that is in the jugulodigastric or the jugulo-omohyoid region, you should always suspect metastatic papillary carcinoma. And papillary carcinoma, we have already spoken about how it spreads via the lymphatics. So it has a nodal lymph node spread. So it is very easy for it to present as a lateral neck mass even before a thyroid nodule has been noticed. In this case, if you do end up finding this, it should alert you to an occult papillary carcinoma of the thyroid with nodal metastasis. And if you do end up finding lateral aberrant thyroid, the management in this case would be first to search for the primary in the thyroid, and then once you have found it, perform a total thyroidectomy with a neck dissection if the nodes are positive. So that's about lateral aberrant thyroid. This can be a whole short note in itself, and it is a very common viva question if you get a thyroid case presentation. Now that we have been talking about nodule, I also wanted to let you know the most common site of nodule development in a thyroid gland is the junction between the lobe and the isthmus. Now that's just a viva question that you should know about. Now we have come to the part of management of the case. So, as I've mentioned multiple times in all my previous case discussions, that management should always comprise of investigations and treatment. Do not straight on jump to talking about the treatment of the patient when you have been asked about how will you manage the case. It's always a very trick question, and we always jump to the conclusion that just treatment is the answer. So, our management will comprise of investigations and treatment. Okay, so moving on, first let's talk about the investigations that we'll perform in our case. So, first of all, you should be doing the thyroid function tests and finding out biochemically what is the what is the thyroid state. Is it euthyroid, is it hypothyroid, or is it hyperthyroid? Second, now, the next two things are not things that you do in all cases, but if you are suspecting a case of Hashimoto's, in this case, you should perform a antithyroid antibodies test. And if you're suspecting thyroiditis, you should perform a CBC and an ESR. These are two things that I'm mentioning over here. But in our case, we are not suspecting any of this, so we'll not be performing these. Next, the first line imaging, which is very important, is the ultrasound of the neck. Now, why will we perform ultrasound of the neck? First of all, we'll confirm the origin of the swelling. We'll look at the size, whether it is solid versus cystic, the margins, calcification, vascularity. We'll detect if present any other nodules so as to rule out multinodular goiter, because the treatment of solitary thyroid nodule and multinodular goiter is very different. In multinodular goiter, you usually perform a total thyroidectomy, whereas in solitary thyroid nodule, you can perform a more conservative surgery. You'll also you evaluate the cervical lymph nodes over here. You'll also look for any other swelling in the neck. And within the swelling that you have just found, we'll look for features of malignancy. Now, there are 4 features of malignancies over here that you can remember. First is it is solid. Second, it is hypoechoic. Third, it has a taller than wide shape. And fourth, there are microcalcifications. So these are the 4 ultrasonographic features of malignancy. And this can also help guide FNSC. So these are the reasons why you should perform an ultrasound of the neck. This is the first line imaging in case of a thyroid swelling. Next is we'll perform an FNSC of the swelling. This is a gold standard. You will definitely should be performing. However, important thing to remember is you should avoid FNSC if the patient is in an hyperthyroid state. You do not want to stimulate the thyroid gland by doing an FNSC at this point. Second thing to remember here is usually FNSC helps you in differentiating between benign and malignant thyroid tumors. However, the only exception here is that FNSC cannot differentiate between follicular adenoma and follicular carcinoma because it is not able to detect the presence of capsular invasion. That is what differentiates the adenoma from the carcinoma. So, FNSC here will not be diagnostic in differentiating between the both of them. And in FNSC, you do the Bethesda system, use the Bethesda system for reporting your findings. We'll talk about the Bethesda system in a little bit. Next, this is another one that usually we will not do. In our particular case, we will not be doing, but I just wanted to mention this. Performing a radionuclide thyroid scan using either technetium 99M or iodine 123, this is only done when TSH is low. At that point, we'll see and we'll try to classify the nodule as either a hot nodule or a cold nodule. A hot nodule are always almost benign, and cold nodules, they have a higher risk of malignancy, about 10 to 20%. Next investigation here is a CT or an MRI of the neck or chest. This is again routinely not done, but you can decide in which case you'd like to do. Usually it is done when there is a retrosternal extension or there's a very large goiter and we want to find out what is the extent of the disease, and in cases of tracheal compression. Last of all, very, very important to do is to perform a laryngoscopy. Why should you perform a laryngoscopy? Doesn't matter whether the patient has presented to you with a hoarseness of voice or not. It is important for you to check the vocal cord mobility of the patient preoperatively before you take the patient up for thyroidectomy, because you need to first record whether preoperatively there was any recurrent laryngeal nerve palsy or not. So that helps you in proper surgical planning. So these are all the investigations we will be doing in a case of solitary thyroid nodule. Now, there are two systems that we need to know here. One is TIRADS, which is in relation to the ultrasonography of thyroid. And then there is Bethesda System, which is used for reporting FNSC findings. So first, let's talk about TIRADS. Now, what is TIRADS? The full form of TIRADS is Thyroid Imaging Reporting and Data System. Now, this is a standardized ultrasound classification system which is used for thyroid nodules. And this helps you in stratifying the risk of malignancy, which is important because that decides the kind of treatment that you will be taking. And second, it provides guidance on which nodules require an FNSC and which can be just followed up. So let's look at the TIRADS chart over here. This is a chart you should definitely remember fully. There are uh, five headings that we look at: composition, ecogenicity, shape, margin, and ecogenic foci. And we'll rate each one of them. You can see that there's a numbering system over here. Depending on what finding you have found, you'll rate them. And then you'll add up all of these five numbers and we'll reach a TIRADS level with that number. If it is 0 points, then it is TIRADS level 1, which means that it is benign and no FNSC required. If it is 2 points, it is TIRADS 2 and it is not suspicious for malignancy. If it is 3 points, it is TIRADS 3 and mildly suspicious for malignancy. If it is 4 to 6 points, it is TIRADS 4 and moderately suspicious. And if it is 7 points or more, in that case, it is TIRADS 5, which is highly suspicious for malignancy. So this is the TIRADS chart that you should be remembering by heart. Next is our Bethesda system, which is used for thyroid cytopathology. All the FNSC results is reported in 6 diagnostic categories, and each of them have a different risk for malignancy and a recommended management to it. So this is the table that shows that. So we have 6 categories here. Category 1 is when it is non-diagnostic or unsatisfactory, meaning that there is inadequate cellularity, cyst fluid only, or a poor smear has been taken. These have the lowest risk of malignancy, about 1 to 4%. In this case, you should just repeat the FNSC under an ultrasound guidance. Second is benign, which could be a case of colloid nodule, nodular goiter, Hashimoto's, or thyroiditis. They have a risk of malignancy of about 0 to 3%. In these cases, we can do a clinical follow-up and repeat the ultrasound. Next is atapia, the category 3, which is atapia of undetermined significance or follicular lesion of undetermined significance. These have a risk of malignancy of about 5 to 15%. In these cases, because we are not very sure, we can repeat the FNSC again. Category 4 is when there is a follicular neoplasm or it is suspicious for follicular neoplasm. It has a 15 to 30% risk of malignancy, and we can perform a diagnostic lobectomy because here we cannot distinguish between adenoma and carcinoma and FNSC. Category 5 is when it is suspicious for malignancy. It has features suggestive, but however not definitive for all the malignancies. This has a very high risk of malignancy of about 60 to 75%. We can perform a near total or a total thyroidectomy depending on the particular case. And type 6 is the malignancy, which is confirmed malignancy. Like it could be a papillary carcinoma, it could be a medullary anaplastic lymphoma, or even a metastatic one. They have the highest risk of malignancy of about 97 to 99%, and these cases should be undergoing a total thyroidectomy and appropriate oncologic management for it. Okay, now we have talked all about the investigation part. Now let's talk about what treatment we'll be performing here. So a treatment for this case, let's assume that this is a colloid goiter case. We will perform a left hemithyroidectomy under general anesthesia. Now that brings us to the question, What are the indications for surgery in a case of solitary thyroid nodule? First of all, the most important one is suspicion or any proof of malignancy. Now, what does that compromise? Either you have cytological proof or like ultrasound features, or you have a clinical suspicion. So, FNSE may have malignant cytology, which showing papillary or follicular or any other such carcinomas. Or there is a suspicious or indeterminate cytology, which is Bethesda 3 and Bethesda 4. Malignant cytology is like Bethesda 5 and Bethesda 6. Or if there is a follicular neoplasm where you're not able to distinguish between adenoma and carcinoma, in this case, also you can perform surgery. And when you have clinical suspicion of malignancy, like there is a hard, irregular, fixed nodule, rapid increase in size, vocal cord palsy, or cervical lymphadenopathy. So these are all the ways you can find if you are suspicious or you have proof of malignancy. Second indication for surgery is when the patient comes to you with pressure or compressive symptoms. So we have the most common one would be the most common one would be dyspnea or stridor. This occurs because of tracheal compression or deviation. It can be because of dysphagia, because of esophageal compression, or if the patient has hoarseness of voice due to recurrent laryngeal nerve palsy, or if there is a Pemberton sign positive, which means there is a superior vena cava obstruction from retrosternal extension. These are all the reasons why you may need to perform surgery in a case of solitary thyroid nodule. Third is when there is a hyperfunctioning toxic nodule which is not controlled medically. So, say there is a toxic solitary thyroid nodule causing hyperthyroidism, but it is not responsive to anti-thyroid drugs, or the patient prefers for a definitive treatment of surgery. In that case, also you can perform a surgery. Fourth is having a recurrent cystic nodule. Say you have a cystic solitary thyroid nodule that keeps refilling after every time you perform aspiration of the nodule. In that case, also you can perform a surgery. Fifth is cosmetic, when there's a large visible swelling causing the patient distress. So in our case, we have a 36-year-old female who is a young female. So cosmetic aspect is very important over here for them. In that case, you should also perform surgery. And last of all, if the patient prefers it or the patient is anxious about it, and some patients may tell you that even though the swelling is benign, they would like to remove it, especially if the FNAC has been inconclusive or they are just anxious that it could end up being a malignant swelling. In that case, also, you can perform surgery in a case of solitary thyroid nodule. So, these are the 6 indications where, in case of a solitary thyroid nodule, you should go for surgery. So in our case, we are performing a hemithyroidectomy. So in very short, I'll just tell you the steps of hemithyroidectomy. First of all, we do this under general anesthesia with endotracheal intubation. The position over here would be supine with the neck extended. We place a pillow under the shoulders. The incision that we give here is the Cocker's incision, which is given 2 centimeter above the sternal notch. Then we incise the skin, subcutaneous tissue, and platysma. Elevate the subplatysmal flaps. The extent of elevation would be from the thyroid cartilage superiorly to the suprasternal notch inferiorly. Then we'll retract the strap muscles laterally and expose the thyroid lobe. Now we have exposed the thyroid gland. Now what the next step would be to mobilize the thyroid lobe. How will we do that? We'll do that by opening up the pretracheal fascia and identify and mobilize the ipsilateral thyroid lobe. Next, we'll divide the middle thyroid vein if it is present. Next, we'll have to go for vascular control. So first, we'll look at the superior pole of the thyroid gland, where we'll ligate the superior thyroid vessels very close to the gland so as to protect the external branch of superior laryngeal nerve, which has a close relationship to it. And at the inferior pole, we'll ligate the branches of the inferior thyroid artery close to the gland to preserve the parathyroid blood supply as well as prevent recurrent laryngeal nerve injury. Once we have done this, next is we have to pay attention to nerve and parathyroid preservation. So we have to identify and preserve the recurrent laryngeal nerve, which is seen in the tracheoesophageal groove, and the parathyroid glands, especially the inferior parathyroids. Once you have done this, we'll preserve this vascularity whenever possible. Next, we'll move on to divide and ligate the isthmus of the thyroid close to the gland. Next, we'll excise out the thyroid lobe along with the nodule and detach from the trachea and excise it out. And we'll send the specimen for histopathology. Then we'll achieve hemostasis and close the wound with or without drain according to your preference. So this is in rough all the steps of hemithyroidectomy. Next, which is the last question for the day, what are the complications of thyroidectomy? Now we can divide this into three. We have intraoperative complications, we have early postoperative complications, and we have late postoperative complications. So, amongst intraoperative complications, there is only two things. One is there can be a hemorrhage or there can be injury to some structures. So, hemorrhage can occur because of injury to superior or inferior thyroid vessels or even middle thyroid vein, and this can lead to hematoma formation and even airway obstruction. Next, amongst the injuries, the first most important one is recurrent laryngeal nerve injury. If it is unilaterally injured, it can lead to hoarseness, and if it is bilaterally injured, it can lead to stridor and airway obstruction. In that case, you can end up requiring a tracheostomy. Third is an injury to the external branch of the superior laryngeal nerve. In that case, the presentation would be that there is a cricothyroid muscle paralysis. So, the patient will have a loss of high pitch voice. And a very rare injury is injury to the trachea or the esophagus. These are all the intraoperative complications. Next are the early postoperative complication which can occur within first few hours to days. First of all, there can be reactionary hemorrhage which can occur within 6 to 12 hours. Patient will present to you with neck swelling, stridor, respiratory distress, and emergency reopening would be required in these cases. Second, there can be an airway obstruction from hematoma or tracheomalacia or bilateral recurrent laryngeal nerve palsy or even laryngeal edema. So these are all the causes why you can end up having an airway obstruction. Third is a case of hypocalcemia or tetany. This may happen because of hypoparathyroidism. So, if you end up injuring the parathyroid gland or excising them by mistake or devascularizing the parathyroid glands, it can lead to hypothyroidism and it will present to you with as a case of hypocalcemia. Features, the most early feature that you see is numbness around the mouth. Other than that, there can be tingling, carpopedal spasm, Schofteck sign, and Trujos sign. An important thing to remember here is when should you check for the serum calcium level. So you should check it only at 24 to 48 hours after surgery because in the first 24 to 48 hours, whatever calcium levels were there in the blood will clear out. And at that point, you should check it to see whether the patient is suffering from hypocalcemia. Next complication is a thyrotoxic crisis or also known as thyroid storm. This happens if the surgery has been done in a case of uncontrolled thyrotoxicosis. Last one is infection, which is very rare because thyroid gland is usually very vascular and very resistant to infections. So these are the early postoperative complications that we have. Last of all are the late postoperative complications, like if there is a permanent hypoparathyroidism, it will lead to chronic hypocalcemia. If there is a permanent recurrent laryngeal nerve palsy, it will lead to persistent hoarseness. If there is an external branch of superior laryngeal nerve palsy, it will lead to permanent loss of voice pitch. Hypothyroidism in cases of total thyroidectomy, or if there has been inadequate hormone replacement after thyroidectomy. Next, they can have keloid or hypertrophic scar. And last of all, there can even be a recurrence of the goiter if a subtotal thyroidectomy has been done. So that's all about our discussion on a case of solitary thyroid nodule. If you have any further questions, please let them know. I'll get back to you regarding that. Thank you.